Pain operates as a rapid bioelectrical communication signal, constantly moving at high speeds through the vast network of the human nervous system. The biological objective of analgesia is to intercept and disrupt this communication signal before it reaches its destination. This ascending pathway schematic shows how the body transmits a pain signal. Analgesics intercept this transmission at 2 points. Non-opioids target the peripheral tissues, where the signal originates. Opioids target the central nervous system synapses, where the signal is processed. We will now map 6 specific analgesics to their exact biochemical intervention points along this pathway. Identifying a drug's specific location of intervention provides the data needed to determine its clinical use and its potential for off-target physiological risks. We begin at the site of a localized injury, focusing on the activity within peripheral tissue. At the site of damage, cyclooxygenase, or COX enzymes, process molecules into inflammatory prostaglandins. These prostaglandins are the chemicals that initiate the pain signal. Paracetamol acts as a weak inhibitor of this process, slowing the synthesis of prostaglandins without halting it entirely. This level of inhibition makes it a standard indication for mild to moderate pain and pyrexia, or fever. The primary risk of paracetamol is found in the liver. An overdose can lead to severe hepatocellular insufficiency and permanent liver damage. Clinicians must exercise extreme caution in patients with a body weight under 50 kilograms, chronic alcohol consumption, or malnutrition. Secondary considerations include potential renal damage and anorectal erythema when the drug is administered rectally. Paracetamol serves as a foundational peripheral interceptor that requires strict monitoring of the patient's hepatic capacity. Aspirin utilizes a more permanent mechanism. It irreversibly inactivates the COX enzyme. Aspirin binds permanently to the enzyme, creating a blockade that stops the production of prostaglandins and thromboxane A2. Because this loss prevents clotting, aspirin is indicated for cardiovascular prevention in unstable angina, myocardial infarction, stroke, and atrial fibrillation. However, aspirin is strictly contraindicated in children under 16 due to the risk of Rye syndrome. Adults with active peptic ulcers or bleeding disorders must also avoid the drug due to its impact on the gastric lining and clotting factors. Diclofenac sodium provides a potent alternative, acting as a dual inhibitor of both COX-1 and COX-2 enzymes. This potent dual action provides aggressive relief for severe musculoskeletal conditions like acute gout, rheumatic diseases, osteoarthritis, and ureteric colic. This potency is balanced against significant risks. Diclofenac is contraindicated for patients with ischemic heart disease, heart failure, or gastrointestinal bleeding. Stronger peripheral COX inhibition provides deeper musculoskeletal relief, but it increases the risk of cardiovascular and gastrointestinal complications. When peripheral treatments are insufficient, the focus shifts up the spinal cord and into the central nervous system. This move to opioid analgesics changes the objective. Rather than dampening inflammation at the source, these drugs alter how the brain perceives the incoming signal. Within the synapses of the central nervous system, mu-opioid receptors regulate how pain signals are communicated between neurons. Tramadol hydrochloride locks into these receptors, blocking neurons from communicating pain signals to the brain. This central blockade is indicated for moderate to severe acute and chronic pain, including postoperative recovery. Because it acts on the brain, tramadol is contraindicated in patients with uncontrolled epilepsy. It must also be avoided during acute intoxication with alcohol, hypnotics, or other opioids to prevent dangerous central nervous system depression. Central interception provides a powerful tool for blocking severe pain, yet it introduces immediate neurological risks. Pethidine hydrochloride, also known as meperidine, functions as a direct agonist at the mu-opioid receptor. Its agonistic properties make it a primary choice for acute pain management, pre-medication, and postoperative care. Pethidine is particularly notable for its role in obstetric analgesia. While it is the analgesic of choice during pregnancy, it carries the specific risk of producing respiratory depression in the fetus. Morphine is the final drug in our model, acting as a highly systemic activator of opiate receptors. Morphine mimics endogenous neurotransmitters, leading to the widespread activation of opiate receptors across the brain and body. This systemic reach allows morphine to be used in cardiovascular emergencies like myocardial infarction and acute pulmonary edema. In end-of-life palliative care, morphine provides essential compassionate management for severe pain, persistent cough, and severe dyspnea. However, this broad activation is contraindicated in patients with heart failure or peripheral arterial disease. Full central agonism provides unmatched relief for severe acute and terminal conditions, but requires the clinician to manage significant respiratory and cardiovascular constraints. Viewed together, the biological pain pathway provides a clear map for clinical decision-making. Non-opioid medications act peripherally to control the chemical generation of the pain signal. Opioid medications act centrally to control the neurological perception of that signal. This clinical matrix highlights the relationship between intervention points and risks. Peripheral interventions carry gastrointestinal and hepatic risks, while central interventions carry neurological and respiratory risks. Effective analgesia is a process of matching a drug's specific mechanism to individual physiology. Safe prescribing requires the clinician to account for variables such as age, liver function, or pregnancy when selecting a molecular mechanism. Treating pain is a challenge in precision engineering, where a thorough understanding of pharmacodynamics serves as the essential tool for patient safety.